of how hormones are produced, how they are acting, and how they have unique features in terms of action from that perspective. And we also discussed what can cause different endocrine disorders in that regard. So today we'll continue that, and we'll use case scenarios to highlight that aspect as well. So we have discussed about the release part. The other issue could be because of a binding protein. And we know binding proteins are important. They are not just there to sequestrate, they are also there to direct that. So one, of course, role is transporter. So all the peptide hormones do not need a binding protein, while the steroid hormones do need a binding protein. And we have discussed that because of these binding proteins, steroids have a longer half-life. They are helped and they are secured by this binding protein from the various enzymes from that regards. And amino acids also do not have a binding protein from that regard. So this is something to remember. But what you also need to remember is that the binding protein is not just a something to bind or increase half-life. It also is a chaperone. What it means is that it can carry that particular molecule to its destination. So this can help you reach out. Can you name of a binding protein for a peptide which actually is part of the receptor also? So there is a very, very specific receptor of a peptide hormone, which in a way sends out its part of the receptor to get that ligand to that particular site. Like if you say you have put a bait, you get the fish and catch it up. No? Growth hormone binding protein. So growth hormone binding protein is actually the extracellular domain of the growth hormone receptor, and it's circulating. So it's in a way very interesting. The half of the receptor is sent into the blood. It catches growth hormone and brings it down. So this is how it works from that regard. So growth hormone basically is binding to growth hormone binding protein, which is actually the extracellular receptor. And it will fit into that intracellular receptor and start acting. Deficiency in this growth hormone binding protein causes which syndrome? So that's the classical Laron syndrome, in which you will have antenatal growth will be normal because growth hormone doesn't play a role. So antenatal growth will be normal, but postnatal will be very severely affected, and then you have to give IGF-1 in that regards. Now, binding protein can also act as the regulator of that particular enzyme. If your binding protein is high, your function will be less. Binding protein is less, function will be high. So we know that growth hormone produces IGF-1 level, and IGF-1 is bound to IGF-BP. If you give IGF-1 from outside, it is not coming with binding protein. So what it means is that in that scenario, what will happen is that your IGF-1 levels will be huge and it will start doing a lot of action. It will cause hypoglycemia, it is going to cause tumorigenesis. But if you give growth hormone, it is going to increase both IGF-1 and IGF-BP. So the free fraction will not be too high and you can regulate that in that regards. So if you give growth hormone and growth hormone binding protein together, do you think that could be a good option? So people have tried, but it has not been because it becomes very difficult then. But theoretically, it is a good option because then you are increasing the half-life of growth hormone also in that regards. Can you think of a therapeutic strategy in which binding protein manipulation is used as a strategy?
Can using like polycystic ovarian syndrome where estrogen or giving should increase the to increase the binding globulin, so the free form of the testosterone will be less.
So hyperandrogenism, basically your testosterone is high. If you increase the SHBG level by giving estrogen, then it will bind to that. So your androgen levels will become low. That is something which is useful from that regards. Now, we also know that insulin inhibits a number of binding proteins. If your insulin is high, IGF-BP will be low, IGF will be more, and growth will be more. Which clinical condition does insulin excess cause high growth? We all know insulin causes more growth, but there's the most common cause of hyperinsulinism is? Yes. So obesity, what will do? Insulin will be high, IGF-BP will be low, IGF-1 will be more, and child will be tall. So everybody who is obese should be tall. If the child is obese and not tall, you are thinking of pathology. So this is through the insulin pathway that becomes important in that regard. So if your insulin is more, IGF-1 levels will be more and growth will be more, as I discussed. Now, growth hormone can also act upon, as I said, increasing IGF, BP, and IGF-1, and that will balance the too much excess of these levels from that regards. So we have talked about binding protein acting as a chaperone, binding protein acting as regulator, binding protein regulating as a transporter. They also act as stabilizer, so which increases the half-life, which we alluded to earlier. So steroids, in a way, cortisol is pulsatile. But the graph that you are seeing is not really pulsatile. Why is that, Alaban?
So binding globulin that is present, which causes stimulation.
So every few minutes, you are putting a stuff in a truck. And then that truck goes every 2 hours. It delivers to its destination. So rather than having too much fluctuation, the final destination will receive in 2 hourly pulses. So in a way, this is being packaged into that binding protein and released slowly. So that really helps out. And this binding protein also helps in storing the compound. So CBG, which is the cortisol binding protein, if you give multiple IV boluses versus a continuous infusion, which is better, and why?
Continuous infusions will be better because if you give pulses of steroids, then the levels will be much higher. Too much to what the level of the saturation of the binding globulin, and that will be excreted by IV.
So they will overwhelm the capacity of the cortisol binding and it will be wasted. So that's why keeping it at a lower level on that threshold will be a better option from that perspective. So binding protein in a way is helping and it's delivering when needed. So it's more like a making it more smoother. All these fluctuations become less if you have a binding protein. Growth hormone doesn't have a binding protein in a classical sense, so you will have that pulsatility there. 10-year-old girl with poor concentration, Nimisha, height is 136, youth thyroid clinically, TSH is normal, T4 is very low. Will you do an MRI? So most common cause here will be abnormality in the thyroxine binding globulin. If the binding globulin is low, you will get a false level. And what are the causes of low TBG? Estrogen increases. So what decreases? Opposite of it, testosterone will decrease. Nephrotic syndrome, the problem could be there. Hypoproteinemia, all those conditions, you will have a problem in the binding globulin and you will have a falsely low T4. So if your T4 is low, TSH is normal, don't rush to central, look at FT4, free T4, which will give you a better picture. Now, thyroxine is very, very interesting. Is thyroxine water soluble?
I got.
Amide means yes or no?
Yes.
Water soluble. Is it lipid soluble?
Lipid soluble, not lipid.
So it's not lipid soluble, but its receptor is intracellular or extracellular?
Intracellular.
So that is the whole point. So how will it then go inside the cell?
This should be a binding globulin by which it will.
So, or a transporter protein. So thyroxine is a unique amino acid derivative. We talked about peptides, we talked about catecholamines, they are all acting on the cellular receptor, membrane receptor. This is going to work inside the receptor, and that's why it has to be taken through the cells. So it is something like you send somebody to the border, the special army is going to take it inside. Otherwise, you are not allowed. So MCT8 is a very, very unique transporter for thyroid, which takes it to its nuclear receptor and where it starts acting. If you have a problem in MCT8, what will be the biochemical profile and what will be the clinical picture? If MCT8 is not there, what will happen to T3, T4, TSH?
T3 will be high. Because it is not going inside the cell.
TSH?
TSH will be high because it can't inhibit, go inside the cell. T4 will be low to normal because the T4 cannot escape from the thyroid cells by MCT.
MCT8 is also involved in taking out the thyroid also. So this is a very unique picture, and this is one area where doing T3 becomes important. And what is their clinical manifestation?
They will be severely hypothyroid, congenital hypothyroidism.
They are ones who have got zero thyroid exposure at all, because even if you have no gland, some amount of maternal thyroid will go and save them. Here they have never been exposed because there is a barrier for thyroid to entry. So they will have the most severe form of, they will have spasticity, neuro problem, developmental problem named as. So this is a disorder, but this is very interesting, a problem in the transporter. So it's not just that your hormone is not there or a receptor not there, the transporter may be defective. So that understanding becomes important. So this is that child, 1 year old with severe mental retardation, low T4, normalish TSH and high T3. This is what you were talking about. TSH may or may not be high that much. So it may behave a bit like resistance, high thyroid, high TSH sort of a scenario. And there are extra pyramidal symptoms. So this is the MCT8 defect.